A very warm welcome, everybody, and thank you for joining our Wounds and Compliance in Aged Care. My name's Carla Beharam, and I'm joining you from Anchor Excellence, and I'm absolutely delighted to be welcoming Kate as well from HARTMANN. And we're looking forward to spending the next hour with you and really unpacking wounds and compliance in aged care. Before we get officially started, in the spirit of reconciliation, the Anchor Excellence team and the HARTMANN team acknowledge the traditional custodians of country throughout Australia and respect their connections to land, sea and community. And we pay our respects to their elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander people joining us today. Ted, I think it's really important that we call out, even though this is a recorded session, the very purpose of doing this session is to align with Wound Awareness Week, which occurs between the 4th and the 10th of September. So we're very keen to be sharing the important messages today, and we would encourage participants on this session to have a look at opportunities where you can really raise the awareness around wounds within your organisation. So whether you're in a residential service, whether you're a home care provider, looking for opportunities that you can be having the conversation about wounds and how you can go about making sure that they're managed in the very best way possible. So let's have a look at some objectives for today's session, and we do have a lot of information to share with you. But at the end of this, we're hoping that you'll be able to really define wounds, have a good understanding of the types of wounds, and understand what assessments are relevant for each particular type of wound. We want to be raising the awareness about the impact of wounds on older people living in residential care and receiving home care services, to promote prevention and early intervention and improve wound care management, understand the correlation between wound management, holistic care, and overall quality of life, understand the compliance requirements around wound management related to the aged care quality standards. So we do have a lot of information to get through, and I know that Kate in particular is really keen on making sure you've got some practical things to take away when you're looking at wound assessment and how we go about providing the best care and management for wounds. It's always great to start with a definition, Kate, isn't it? Because it helps set the scene and the context of what we're looking at here. So very simply, we know that a wound is an injury or impairment to the integument or underlying structures that may or may not result in the loss of skin. We know absolutely that wounds are caused by a variety of factors, such as trauma, surgery, or underlying medical conditions. And I think if I think about the context of the environments that everybody's working in on this session, a lot of our consumers or clients or residents all have multiple comorbidities that contribute to the impact of wounds. They can range from in severity from minor cuts or skin tears or scrapes to deep lacerations, complex surgical wounds, and or chronic leg ulcers. And again, if for everyone on the session watching this session, I'm sure that you could all be thinking about a couple of people already top of mind who have these particular wounds. So important just to set the context there. Kate, over to you.
Thanks, Carla. I think it's a really good way to start the session by just talking about skin. You know, we're going to talk a lot about wound and wound assessment. But if we take a step back and look at why skin's important and why it's important that we're taking preventative strategies every day to promote skin integrity and that overall holistic well-being and health so that we are preventing wounds from occurring. So we know that skin is the largest organ in the body, and we know that as part of the aging processes, there's natural components and changes that occur to skin that causes skin to be more fragile, more vulnerable to wound damage. So if we think about aging skin, so that's over 70, 80 years of age, it's had a lot of exposures, whether that be to environmental factors. You think about impact of sunscreen wasn't readily used back in 50, 60 years ago. So we really want to be doing what we can to promote it and maintain it. If we look at the acid protection mantle layer, so that's that blue line on top there. So this is a very fine, slightly acidic film that acts as a barrier. Now, this is skin likes to be at a pH between 4.5 and 5.5. Why that's important is we'll go into the next slide. But everything we do, we want to maintain skin integrity, but importantly, the acid protection mantle layer. If we think about some of the changes that occur as we age to skin, there's a reduction of collagen fibers, there's a reduction in the dermal thickness, there's a reduction in blood vessels, thinning of the epidermis and flattening of the epidermal junction, and reduction of elastin all impacts the likelihood and the vulnerability of that aging skin. So you'll see on the next slide that I'm going to talk you through some of the Molicare and Hartmann skincare products. And the idea here is to really just resonate with you about that skin pH. So you can see down the bottom that pH scale where skin likes to live, that 4.5 to 5.5 pH range. If we're constantly exposing the skin to substances that are higher pH, whether that be urine, feces, you think pelvic region with residents who may have some incontinence, or even soaps and water, which are higher pH as well, that's all impacting the acid protection mantle layer. So with the Molicare skincare range, all these products are in the skin-friendly pH. And you can see here on the screen, we've got our wash gloves featured, the wash lotion, which is a great alternative to regular soap. Regular soaps, that 10 pH. So if you're already combining factors to resident skin or client skins that are, greater susceptibility, they're a high risk, they've got a constant exposure to moisture, they might have diabetes, they might be on warfarin, all those compounding factors, using something like a wash lotion that's pH balanced is a really good initiative to support. We've also then got there our cleansing foam and cleansing tissues, which are great to support hygiene, post-incontinence. Also here, the barrier cream, which is super important when we're talking about prevention of skin to that pelvic region. We know IAD is a quality indicator, and Carla will talk about that a bit later. But super important, we're protecting the skin and applying a barrier cream of some sort, and one that's transparent and isn't going to then impact the absorbency of a pad is also really important. And then we've got the moisturizer. And we know that evidence supports that applying a moisturizer, a quality moisturizer twice a day can help reduce skin tears by up to 50%. So if you'd like any more information on these products, feel free to reach out after the session. Email, contact details on the end. But, all those ingredients that really can help regenerate that skin and help promote skin integrity.
Okay, what I'd add in there from our experience and what we've seen is the importance of obviously choosing the right product for each individual. Now, it is important that it's not a one size fits all approach, and I know that you're going to talk about that as we go through, but really paying particular attention to the individualized regimes that you can actually support people's skin with.
Yeah, really important, because it's, we don't want a cookie cutter approach. We really want that person-centered holistic approach. Some residents may prefer a barrier cream, or some may prefer a barrier foam. And I guess it supports that health literacy as to why we're doing it as well, to support the skin integrity with those outcomes.
Okay, so let's have a look at a couple of common types of wounds in aging skin. Now, anybody working in a residential aged care service or a community home care service would absolutely be familiar with skin tears. So a skin tear is a traumatic wound caused by mechanical forces. And if you think about it, it could be the removal of adhesives, and the severity may vary by depth. Now, I'm sure that all of us can think about instances where we've cared for people with skin tears. And if I think about some of the reasons, my experience why they might have been caused, other reasons could be manual handling. It could be because one of your consumers is particularly mobile and maybe bumping into things. They've got that tissue thin skin. So there's many reasons why skin tears can be caused. Pressure injuries, again, we know that this is one of the quality indicators that we report on. A localized injury to the skin and or underlying tissue, usually over a bony prominence resulting from pressure or pressure in combination with shear. And again, calling out here, we'll touch on it a little bit further on, but we report on these as part of our risk-based questions through our assessment visit, accreditation visits as well. There's been a far greater amount of attention around IAD, or incontinence-associated dermatitis, and this is skin damage that's associated with exposure to urine, stool, or a combination of both, and we're going to talk a little bit more about that as we go through. We also know that there's leg ulcers, and these are defined by underlying vascular etiologies or diseases underlying pathophysiologies. And we know that they're typically arterial, venous, mixed, or neuropathic. So again, for everybody on the session today, thinking about what is your mix of wounds that you have in your service or in your service delivery at the moment? What are some of the things that you're seeing for your clients and community consumers out in the community? What are you seeing as part of the mix of wounds within your residential services? And again, of course, surgical wounds. Now, these may not necessarily be quite as common in residential aged care services, but absolutely in the community, you may be seeing more of these as people are having surgical procedures and then returning back to their home environment. So surgical wounds, wounds that occur as a result of surgery. Let's go back to something's not working here with my, there we go, practice. There we go. I'm going to hand over to Kate for practice and standard.
Thanks, Carla. Now, there's a lot on this slide, but I just want to start by really setting the scene in any wound management approach, and going back to that skin integrity approach as well. We always want to be looking at the whole person, and it's not just the hole in the person. When we're thinking about whether it be a consumer with a significant leg ulcer, or it might be a skin tear that we think might just be a simple skin tear and should heal on a regular trajectory. If we're not taking into consideration that whole person, what their needs are, what are other factors that are going on, it can impact that healing trajectory. So when we're talking about a healing trajectory, we talk about the healing phases, and typically for a wound, not typically, but for a wound to heal, it will go through these 4 key phases. So we know that hemostasis is when that wound first occurs, goes through the inflammation phase, and typically if a wound becomes stagnant or becomes hard to heal, that's where we'll see it can become stuck in that inflammation phase typically. Then when we go to the proliferation phase, this is where we get that granulation, epithelialization of tissue. So thinking about when you're a wound that you may have dressed recently or you've seen, it was recently acquired, then you can see it go through that process of inflammation, all the symptoms that go with that inflammation process. And then if we see that wound starting to heal and progress, you can see the edges starting to advance. You can see the granulation tissue change. So identifying the healing phases is a really good process to then be able to align to, well, what are my goals with this wound right now? Okay, if it's granulating, what do we want to do to protect that granulation? If there's a lot more inflammation going on, there can be more exudate. If there's more exudate, we need to manage the moisture. So it's important to have that understanding of what the wound is, but then also what healing phases it's in. Here I've also I've also got then the next healing phase is the remodeling or the maturation phase. And the important thing to remember here is that when a wound is healed, when it looks like it's healed, it's 80% the tensile strength of what it was. And it can take up to 2 years. So if we have had a resident or a consumer in the community who's had a pressure injury, say it was to their heel. Now, if that wound has healed, it's still only over 80% the strength. So when they're in bed at night or when they're sitting with their shoes on or whatever it is, thinking about what risk mitigating strategies are we also putting in place, because we know that that skin to that area is 80% the strength of what it was. So it's a greater risk for reoccurring. One of the other things when we're talking about practice for wound care is an acute wound or chronic wound? And there's a lot of changes in the literature around chronic moving to hard to heal wounds. And it's more of that nomenclature going from a chronic wound. We acknowledge that it's a chronic wound, but with a hard to heal wound, we're really acknowledging all those contributing factors that impact a wound. They might have diabetes, they might have peripheral vascular disease, all those compounding factors. So looking at those factors, and then putting a plan in place, which really aligns well with the goals of wound management. So thinking, is the wound healable? Most wounds will be healable, but there will certainly be some that the goal may be to maintain it, or it may be a non-healable wound. So if we're thinking about a healable wound, we're thinking that there's adequate blood flow, and the cause can be corrected. So i.e. a pressure injury, if we're put in factors to reduce that pressure and the correct wound environment, the wound should heal. With your maintenance or your non-healable wounds, the emphasis really changes from wanting to see a reduction in the surface area to an emphasis on comfort and to an emphasis on symptom management. If you think about maybe a fungating cancerous wound, we know we're not going to heal that, but there's certain factors and goals with that wound management that we really want to consider. That might be the exudate management, that might be the odor, that might be pain related with it. So thinking about those specific goals, if we've got a large amount of exudate, it might be lower leg ulcers or that fungating wound, we want to have a dressing that's going to contain that exudate in, lock it in. So something like a ZFit Plus or something that has those super absorbent polymers in it that's going to absorb the exudate, because they can absorb up to 100 times its own size. So it's really important that it's locking that exudate away, because then it's also protecting the peri-wound as well. And then we go to wound balance. And wound balance, you'll see a reference on the reference slide that refers to a white paper. And this white paper is all around wound balance. Now, when we talk wound balance, we're talking about a multifactorial approach, and it really aligns with that holistic person-centered approach. We want to encompass all the interconnecting issues related to hard to heal wound process, but also our clinical practice, which means thinking about our wound assessment, our wound dressings, the environmental factors, those intrinsic and extrinsic factors as well. So we think about the wound bed preparation, and on the next slide, I'm going to talk through time as a wound assessment mnemonic a bit more. But then we also think about debridement. Now, when we say debridement, I don't necessarily mean, conservative sharp debridement with a scalpel and forceps, which a lot of people comes to mind straight away. But with debridement, it's, it can be autolytic debridement. Or if we just think as a general term of debridement as a removal of non-viable tissue and cleansing of the wound bed, which is really, really important when we're doing that assessment and aligning our debridement and our nursing interventions back to those goals of wound management as well. If we're maintaining a wound or the goal is to treat those specific symptoms of a wound, our actions around debridement and may be different to that if it's a healable wound. So important that we understand to start with, what is the wound? What type of wound is it? What's the underlying etiology? What are our goals? And then how are we going to work to achieve that wound balance? And then we go to exudate management. And this is really important because moisture balance is critical. If you think back to an original study, George Winter in 1960, when he did his study around moist wound environments and wound healing, with the two pigs comparing a dried wound to a wound that had a film on it. And that was where moist wound environments came from, and that importance of exudate management and moisture balance. So thinking about, we want to balance that wound, and then we're looking at those holistic factors. So this is this flowchart you can see here is taken from the literature, the articles Wound Bed Preparation. And they've got 10 best practice statements around wound bed preparation. And again, it's linking to that person first and foremost, because if we're not thinking about that holistic person, we're going to miss something. And then we're identifying the cause, thinking about those contributing factors, and then determine the ability to heal. And then we're going to that local wound care, which we've got the wound balance, the debridement, thinking about inflammation, and then thinking about moisture balance. And then also thinking about that edge, because we know when a wound's starting to heal, we can get that edge, epithelial edge advancement, which is what we want to see if the goal is to heal.
Okay,
the other resource, sorry, Carla.
Sorry, Kate. I just wanted to pick up on something that you've said before about a wound is going to be only 80% of the strength that it was prior to the wound occurring, or the skin. And I think that's a really important factor for people who are on the session today to be thinking about, as you talk about how do we manage things differently now? How do we make sure that knowing that a wound or a skin integrity or the strength of the skin is actually going to be 80% of what it should be, what are the extra things that we need to be doing for that person? And I'll touch on this a little bit in the documentation side, but how do we make sure that we're capturing that well enough so people are really clear about that and understand that?
Yeah, it's a really important point. If it's not handed over or communicated, or in our assessments that consumers had a previous pressure injury, it's healed, or even leg ulcers or a skin tear, thinking about those common areas, like you said, with skin tears, on the arms or limbs, whether it be from knocking, they're such a high risk area.
Yeah. And Kate, the other thing I just wanted to touch on before we go to the next slide is I actually love this diagram. I'm a really visual person. So for me, I think there's really great opportunity for people on today's session to be thinking about how you can use this within your own services. So, it might be that you've got some copies of it available in treatment rooms or medication rooms. If you're out in the community and you don't have all of the paper stuff, it's how do you make this kind of flowchart available for people so it's top of mind? So at a really quick glance, we're thinking, these are the things that I want to be thinking about as part of my standard practice when I'm reviewing wounds, or how am I actually going about supporting someone? So I'm always thinking about what the person-centered approach is. I think this is a really great diagram.
Now, this is the time mnemonic that we talk about, and we all know time front of mind. But when we talk about time and wound assessment, we're talking about the tissue management. So start off by thinking about, what type of wound is it? And then with the tissue, is it, is there necrotic tissue? Is it slough? Is there slough? Is there granulation? Is there epithelialization? So identifying your wound type and then identifying the tissue is a great first step. Then we're going to look at our wound edges. And then we're going to make sure we're measuring our wounds at, widest length by longest length by longest width. Assessing if there's any depth is really important as well. And then if there's any undermining or sinuses, there's literature that supports, using the clock face as well to assess undermining. So really making sure we're getting that size, because if we're not measuring, it's really hard to understand where we've come from and then be able to ascertain if the wound's deteriorating or is it healing. Because that's part of that reassessment process. Then we want to make sure with the tissue management that we've identified the right goal. So that's step before in that flow chart when we're talking about the goal. If we're going to want to heal this wound and the goal is healability, getting that, removing any slough, using debridement to remove any of that devitalized tissue. So we've got the cleanse and the decontaminate under the T and the I. So with I, we're talking about infection and inflammation control. And I will just call out a really great resource that's free and readily available, and that's the International Wound Infection Institute. And they've got their Wound Infection Clinical Practice Guideline. It's referenced at the end, but it's got a beautiful infection continuum that really supports your infection prevention control, what, whether a wound is contaminated or colonized, and what different infections would look like in a step up and step down manner. So when we're thinking about biofilms and we're thinking about infection, really important that we're identifying these signs early on in a wound so that we can kickstart that healing trajectory. When we go through I, we are going infection and inflammation. And we want to make sure that we've, identified it, we've put things in place, but then also we've got the right dressing. And I'll touch on the dressings in a second. When we go to M for moisture, moisture balance is so important, because if a wound's too wet, we're going to impact that peri-wound area. We're going to impact the overall pH of the wound, the temperature. So we want to have that moisture balance right. And that's why it's important to have those right dressings that are going to support that. When we go to E, we're talking about the epithelial edge advancement. So we want to protect that the epithelial cell growth, and we want to protect those edges as well. So that's how we would use time to support our wound assessment. So with your wound assessment, you've identified the type of the wound, you've identified the wound bed, you've then identified the wound edges, you've done your measurements, your length by your width by depth. You've identified your exudate, and what is your exudate telling you? What is the amount? What is the type of exudate? You're identifying if there's any odor. You're also assessing your peri-wound area, so the area around the wound, which is really important. And we're also assessing any pain. what's the pain when you're doing the wound, what's the pain before, and the pain after. And I'm sure Carla can touch more on pain shortly. When we're doing our wound assessment, we want to make sure we're also understanding the underlying etiology, because what is the cause? If the wound, if we think it's if we're thinking it's a skin tear or a pressure injury, and we're treating it because of that underlying etiology, and we've got that treatment plan in place, but then it's not healing, asking those questions, well, why? You know, is it maybe a skin cancer? Or because we want to make sure we've got that etiology right, so then we're putting the right treatment plan in place. And then also identifying those factors that are impacting wound healing. And then that goes back, links to that previous slide where it talks about the wound balance and the healability. If we can identify factors that are impacting wound healing early on, and then we're risk mitigating where we can, or putting interventions to support that wound healing, we're going to get better outcomes. So thinking about, you know, aging, the aging skin impacts. So how can we support that overall skin integrity? How can we risk mitigate potential pressure? And we go into some holistic interventions after talking about, you know, equipment and those sort of things. Thinking about nutrition, the importance of exercise as well, mobility. One of the key things the literature really talks about is the importance of setting goals and working with the person in that health literacy. So whilst this time poster talks about the specific wound, I think it's important that we also talk about those holistic strategies as well. What I was going to touch on now is just linking to the products that are relevant to time. So if you think about a wound that you've dressed recently or assessed recently, and then work through that time protocol. So time, we're looking at that tissue management. Then we're going to look at the infection inflammation control. So there, the goal there is to clean and decontaminate. So a couple of dressings that HARTMANN have that align with your T and your I. And it's probably important to note that we do have a much broader wound care range, but these are just some core products in the range that we refer to as a Simply, that really help reduce multiple different dressings being used and helps create consistency in clinical decision making. So under your T and your I, we have HydroClean. HydroClean helps with autolytic debridement. It has Ringer's solution in it, which can support with that rinsing and cleansing of the wound, and it pulls any of that wound debris into the dressing, and it's locked away because it's got the super absorbent polymers. So you think about the goal of your wound, and we're thinking about if we're going to debride, how can we do that? HydroClean is a really great one to support autolytic debridement. HARTMANN AG is essentially a low toxicity silver contact layer dressing. And then when we go to moisture management, it's really important we're going, okay, if we've got a highly exudating wound, we need something that's going to absorb it. So we need something that's got super absorbent polymers in it that's going to lock in that exudate. So it's not going to leak back out into the skin. If you've got residents that have consumers that have compression on, it's really important that it's going to lock that exudate in and not leak back out, which is then going to impact that wound healing ability. The other product here you'll see is the ZSpit Plus Silicon or Silicon Border. So that's a siliconized super absorbent polymer dressing. So it's still got the still going to lock in exudate, but it has a silicon interface, which is really going to promote that moisture balance as well. So it's a really great option for someone with that moderate exudate management. And when we're thinking about the E, you know, your options are a HARTMANN Silicon, which is a contact layer, if you're looking for a contact layer, or we've also got, I think, a foam dressing, and proximal is an option there as well. So this is just to support you with your wound assessment process, and then linking to what are my goals and how are we going to get consistency to get this healing trajectories and move through those healing phases.
Okay, one of the things I just wanted to pick up, and again, you've said some really, really interesting things, and the thing that just occurred to me was having the right product range for consistency of clinical decision making. And again, I know in a lot of the work that we've seen where we've supported organisations with either system improvement or addressing compliance issues, one of those really big factors, it's almost been like a candy bar where people have been able to go, oh, I might try a bit of this or I'll try a little bit of that, and not necessarily having that consistent approach to say, these are the products that I would use for this particular type of wound. So as a bit of a checklist for people on the session today is to go back and review what products you actually have in stock. Now, obviously, today we're talking about the HARTMANN's products. But if you're not a HARTMANN's user, also have a look at your own checklist to say, do I have things that support tissue management? Do I have the right products that support infection and inflammation control? Have I got the right products to support moisture balance? And the final stage of E, the epithelial edge advancement. Asking yourself those questions will probably, I would say, give you a bit of a stock take or a reflection on your current products and an opportunity or a continuous improvement almost to say, well, let's review what we've got in stock. And then, of course, Kate would be the person that you'd want to be getting in touch with to talk about those things.
Yeah, it's a really good point, Carla, because, I've seen as well, homes that have multiple different dressings, and it can be really confusing for the nurses on the floor. They may only know a couple of them, or thinking about if you're changing the dressing regime every time a different nurse does it, it can impact that wound healing, that trajectory. So yeah, creating consistency of pathway to support clinical decision making and those outcomes as well is a really great way.
Yeah, and Kate, the other plus side of that, just before we move on to the next slide, obviously from a fiscally responsible point of view or a cost containment point of view, there's absolutely advantages to getting your product range right. The whole sector's under financial pressure. I don't think anyone would deny that. So wherever you can make some savings, where it actually benefits the consumer as well, is definitely a good thing to be thinking about and checking for.
Yeah, this SKU reduction and is certainly a great way to do it, because otherwise having multiple different products that do the same thing, it's just going to add up and really will impact those bottom lines.
Yeah.
So the Braden scale assessment tool is a pressure injury prediction for risk of pressure injuries. If you think about the risk factors it has on here, it's assessing moisture, activity, mobility, nutrition, friction and shear, and also that sensory perception. So, when you were doing these, it's not just to go, well, what is the risk and what's the number, but super important. Then we're linking it back to, well, what interventions can we do? And how can we then evaluate the effectiveness of these interventions? If someone is a high risk and then they develop a pressure injury, using your tools to still reassess and go, okay, well, now are they a higher risk? Or perhaps they're still the same score, but maybe they're a higher risk in their sensory perception now compared to, where they were prior. So then that may need additional intervention. So it's a really good tool to go back to and think about those key risk parameters and what else can be done.
Thanks, Kate. I think between you and I, we can probably cover this slide, because it's important that we think about the impact of wounds on the whole person. So we know for sure that the impact, there's the pain element that we need to be thinking about. So if we know from our own experience, if we're in pain, chances are there's going to be a flow-on effect to our appetite. Probably not going to feel like eating a whole lot. I'm going to eat smaller meals or less frequently. I'm a little bit off my food. Weight loss, pain can impact, and obviously impact on weight loss and your ability to sleep. Now, we know that all these particular three factors are all an important part of a healing process. So if you're not getting good nutrition, as Kate's talked about, if you're actually not well rested, then it's going to impact on your ability of the wound to heal. There's opportunity for infection through wounds. And again, if we think about the impact of an infection, can make you feel pretty lousy. It can, for people who are living with cognitive impairment, they may actually, the flow-on effect of infection may actually be manifested through changes in behaviour. So again, a really important thing to be thinking about, getting infection under control and reducing the risk of infection. The impact of exudate and odour. And I think, Kate, for me, this actually is probably one of the really important things that can sometimes go unnoticed. And there's a couple of other points there where we've got decreased quality of life, social isolation, and self-esteem. I think these 3 points almost go together as a direct effect of exudate and odour. we may have people who are experiencing exudate and odour through their wounds. Chances are they might not feel like going out to an activity in the way that they normally would. They may be a little bit embarrassed, or they may be worried that when they go out, gosh, is somebody going to be able to smell that odour? Am I going to have leaky wounds when I go out? So even though there's the physical impacts of wounds, it's also important that we're thinking about the emotional and social impact of wounds and the effect that they can have on people's quality of life. We've talked about the fact that there's increased self-esteem and thinking about the increased care dependency. So if we've got the more complex your wounds are, typically the more care that you're going to need to support your day-to-day function. Impact of wounds, we can also have a look at, it may result in a change of routine. And the classic example, Kate, I think in a residential aged care service would probably be, normally our flow of the day would be to do wounds a little bit later on in the day. However, if we've got a resident who wants to participate in a particular activity, we need to be giving consideration to how we need to change our routine to support that person's preferences.
Yeah, really, I think that's a really important one, because I think it's easy for some residents will go, no, I don't want my wounds done. Or,
yeah.
I think of a resident who I've worked with previously, and he would refuse his wound care. And it wasn't actually about the wound. It was that he wanted to be out having breakfast and then wanted to sit on the balcony with his tomato plants. And that was what was important to him. So it's understanding how that change in routine can really have that flow-on effect for not just the wound care, but also that holistic sense of quality of life as well.
Yeah. Okay. The significant impact on cognitively impaired. Did you want to touch on that one?
Yeah, I think it's one of the key things there is, wounds, as you touched on with the infection, the linking of pain. We know that pain can be sometimes difficult underreported sometimes as well in those with a cognitive impairment or those living with dementia. So making sure we're capturing those pain, infection, as you said, greater risk for escalation of behaviours, but also that flow-on effect of potential delirium. So thinking about how we can link dressings to being as minimally invasive as possible. If we've got if they find when we're doing the dressing, it's quite invasive as well, or can be, quite difficult, using a dressing that maybe can stay on longer, that's going to last. We don't have to address it daily. The other thing I was going to touch on when you're talking about the financial point as well before, think about the impact of wounds. Wound care can be quite costly. But I just want to give you an example. If you've got a skin tear that has occurred and you're thinking about dressing it with maybe like an island dressing or a film dressing that's maybe quite cheap, maybe say 20 cents for round figures, 20 cents a dressing, that may only last a day, so that may need to be changed daily. Think about the compound fact of that every time we're changing a dressing, we've got nursing time to do the wound, resident time, potential pain, also the flow and effect of documentation. So that wound may also then be stagnant or slow to heal because we're not actually contributing anything with that wound dressing. It's just an island dressing. Whereas if we're using something that's going to help promote that wound balance, it may be $1 or maybe $2 compared to your 20 cents when you're comparing piece for piece, but you won't need to change it daily. It may be able to stay up for 5 days, 7 days. It's going to help with that wound balance. It's going to help promote wound healing. It's going to be save the resident having that wound done every day, and it may heal. It may heal after 2 or 3 times at a 5-day regime. So it's healed with 3 dressing changes, as opposed to being changed every day and your costs then add up. So I think it's thinking about not just comparing piece for piece, but that flow-on effect and the holistic solutions with wound care.
Yeah, that's a really great point, Kate. And just before we move on to the next slide, I challenge everyone who's on the session today, and I guess this is, as a clinician, I would encourage you to always be thinking about the so what factor. So anytime we're working with our clients, we might be dealing with an issue, for example, you know, my resident Carla has got reduced mobility because of a wound that she's got on her left heel. Okay, so what? What does that actually mean for Carla in every aspect of her life? Doesn't mean that, well, Carla's probably going to have a little bit more pain in her left foot, so I need to change her medication regime to support her so that she can actually still do the things that she wants to in her day-to-day life. Carla's feeling a little bit embarrassed about her wound because she's got some exudate and odor with her wound. It's going to impact on her social isolation. So what? So what are the things that I need to be doing as a clinician or as part of a broader care team to make sure that we're reducing the impact that's happening from all of these particular factors? I love the so what factor, because, you know, lots of things can be raised in your day to day, but if we're always saying, well, what if, or what else, or so what does this actually mean for the person, we find that it really gets to the heart of what the issue is and puts some practical things in place to deal with the issues.
The other thing I was just going to add there, Carla, is that we talk about the holistic sense and quality of life, but also that psychological well-being, the psychosocial well-being. And there's, you know, evidence to support that if the consumer with a wound has, you know, depression or anxiety, or they're feeling stress, it has a direct correlation to the delay in that wound healing, plus that flow-on effect as well. So just thinking about those other impacts other than, you know, just the wound itself.
Yeah, that's right. Okay, thanks. All right, so let's move on to the other elements of our webinar today. So having a look at some of the compliance requirements and things we want you to be thinking about in terms of the standards. So these two wheels should be very familiar to people on the session. The one on the left side in particular, which is our current aged care standards. And then the wheel on the right-hand side is where we're looking at moving as part of the new aged care standards. So even though we don't have a final date for implementation yet, it's all a little bit dependent on the Aged Care Act. I think most of the conversation that we have that's coming through, and certainly through the Commission themselves, talking about looking at a 1 July for next year. But what's important to really highlight is that wound care connects into one, if not more, of the aged care standards. So under the current standards, we know that there's a direct connect to standard 1 around treated with dignity and respect, standard 2, assessment and care planning, standard 3, safe and effective care, standard 6, open disclosure when things go wrong. And this is a classic example of this could be around a wound that is that deteriorates where we haven't given the wound management. Standard 7 is making sure that we have a workforce that is trained and equipped to manage wounds appropriately. And under standard 8 is the overall clinical governance. And under standard 3B in particular, we know that high impact and high prevalence risk calls out effective management of wounds. Under the new standards, again, we see that it's not just one area where wound management would connect in. Of course, it's connected to the person, and we've talked lots around the fact that we want to have individualised and person-centred care. Under standard 3 of the new standards, it's the care and the services. Under standard 5, it's clinical care. And of course, under standard 6, which we've talked about a couple of times, is the impact of nutrition, food and nutrition on the way wounds can heal. So I just wanted to put that in there because it's an important consideration for you all to be thinking about. We're driven by compliance. It's as a minimum standard, we need to make sure that we're covering these important things. The other thing that I wanted to, I guess, touch on today is where we see organisations and providers have difficulty around either complaints management or compliance. And we know that wound management was one of the most common complaints noted in the sector performance report. So if you're not already connecting into the sector performance reports, we'd really encourage you to do that. They're available every quarter through the Quality and Safety Commission, and they give a really high-level oversight around what's going on in the industry, what's being seen through assessment contacts, what some of the complaints issues are, what's happening through SIRS. But we can see down here on the right-hand side in our graph we actually talk about healthcare and wound management features in the top 10 of the most common complaints that have gone through to the Commission. We know that 5.8% of residents living in residential aged care facilities are living with one or more pressure injuries. And this is where we start thinking about incontinence-associated dermatitis and pressure injuries. We know that they're now a much greater focus through the National Quality Indicator program. So we're still waiting on a little bit more data around the IAD, Kate, but we definitely know that that's becoming a greater focus. Now, the reason, if you reflect on all of the quality indicators that are in place, the reason that these are a focus is because these indicators are the ones that cause harm to people and compromise the people's quality of life. These are the factors where we know that if we can manage these appropriately, actually, we're going to be able to be much better at delivering a safe and quality experience to the people who are receiving aged care services, whether they're in a residential aged care service or in home care. So always remember, when we're collecting this information, there is a purpose. There is a reason that we're checking these and collecting this information. There's a reason that they're a focus. It's because, as I said, if we can get these risk factors under control, quality of life improves for people receiving care. I do want to draw your attention to a clinical alert that came out through from the Aged Care Quality and Safety Commission. And it was basically talking about the fact that incontinence-associated dermatitis is actually a really important thing for providers to be looking at and managing and thinking about within their services. It talks about the fact that incontinence-associated dermatitis and pressure injuries are commonly confused. So calling out the importance of being able to identify the difference between the two. So in your services, thinking about, well, how are my teams being supported to understand the difference between both? Have they been given the right education and training? Could you yourself tell the difference between IAD and pressure injuries? How do you make sure that your teams are confident to do that? And the Commission's also calling out that both conditions must be adequately assessed and monitored. Okay, so if you think about the way that you document, they're talking about including photographic monitoring where appropriate. And we're going to touch on the documentation side of things soon. But it is important, again, where we're looking at these clinical alerts, these are being called out because somewhere along the line, somewhere in the industry, these have actually caused significant harm to people. This is why it's now a focus through the Aged Care Quality and Safety Commission. Kate, is there anything else that you wanted to add on that slide?
I think it's just the importance of linking IAD and pressure injuries, and really then starting, if there's ever a wound to that pelvic region, starting with going, okay, it's to the pelvic region, which means it could be an incontinence-associated dermatitis or it could be a pressure injury, not jumping straight to it could be a pressure injury, because then we've got to start with that differentiation. Okay, well, why is it? Why could it potentially be an incontinence-associated dermatitis? So if the consumer is incontinent, it could be both. And then going through the presentation of the wound, we know with a pressure injury that the definition and that it will be non-blanchable. We know that with an IAD, the edges will be diffused and blotchy. If the skin is broken, it will be superficial. Whereas we know with a pressure injury that the edges will be quite clear and definitive. So thinking about those, the resources and the supporting tools that you have to support your teams. We've got on the resources on the last slide, we've got one that really shows the key characteristics of each and can support with that documentation. We've also got an IAD that's an IAD identification and prevention guide that can support with what are the risk factors, because that's the key thing. We talked about the Braden scale, but also then knowing what are your risk factors for an IAD so that then you can put in those preventative strategies. And then if an IAD does occur, what additional strategies can we put in place? The other thing to remember is that if a consumer has an IAD, they are at a greater susceptibility to a pressure injury occurring. So that's why it's so important to do those regular reassessments and up the ante, I guess, with the interventions if an IAD or a PI is present.
Thanks, Kate. Really, really good info. So let's have a look at some of the key elements around wound management. So bringing together a lot of the things that we've talked about here already. So making sure that we have the right wound product, because we've talked about the fact that the wrong dressing can actually impair wound healing. So making sure that we have the right wound product for that point in time, and reviewing and constantly assessing to make sure that it is indeed still the right product. The importance of moisture, and Kate touched on the fact that making sure that you've got the right pH, making sure that you don't have an over-exudating wound, making sure you've got that under control. The importance of good skin care. And for me, that's again about that preventative approach and that proactive approach. It's not leaving it till people have got something going wrong already. Let's get on the front foot and make sure that we've got good skin care available for everybody that we're providing care to. The importance of understanding goals and treatments for wound care. And again, this is where, if we think about the standards wheel and the way that it is, it's individualized treatment, making sure that we're really understanding what this person needs and making sure that there's dignity and choice for that person involved.
And that really links back to that flow chart, Carla, as well. Yeah. Thinking about, well, what's the healability here? What are the goals of the wound? And then linking to, well, what's the consumer's health literacy? What are their goals? And then intertwining those and coming up with a really personalized wound treatment plan.
Yeah. And by far, the thing that we see services have the most difficulty with through the commission is the documentation side of things and the photography. Now, I can't oversell to you the importance of having good assessment, regular assessment, and assessment that is actually current and up to date, making sure that your care plans are constantly reviewed. And I know in some organisations it would be about saying, well, minimally 3 months. But within your own services, you would know where you've got very complex wounds, people who are requiring far greater support, then care plan reviews and updates would need to be far more frequent than that. Making sure that you're reflecting back on your organisation's policy and process around wound management. This is a really important one that connects to governance, actually, Kate, because policies and processes are there to guide people and help them understand what is it that I need to be doing in this space. Now, if your policies and processes aren't clear, then it's actually very difficult for your teams to deliver that consistent clinical care each and every time. So paying particular attention to when was the last time that your policy and process was reviewed. If it hasn't been for a while, then I'd absolutely be encouraging you to have a look at that and get that review done.
Yeah, Sorry, Kate. The other thing I was going to add on that documentation is when you're doing your assessments and the photography, making sure if a wound, is the wound healing or has it deteriorated? And that was something we probably should have touched on in the time slide. But if your wound's deteriorated, making sure you've documented how it's deteriorated and why it's deteriorated. Linking to, whether it be the infection continuum or has the wound size increased? Is there more inflammation? Has the exudate changed? So that's why having that rigorous wound assessment processes that captures each component of that wound assessment, as we talked about, the wound bed, the wound edges, the exudate, the odor, all those parameters. And where each time we're reassessing each of those parameters, because a change in one of those can indicate, well, something's going on here or something's changing. So making sure we're, assessing and documenting those changes to capture any deterioration so we can act on it.
Thanks, Kate. Photography. Again, like documentation, making sure that you've got clear photographs that are going to actually help you in managing this wound. Many, many times we see wounds that are either the picture's blurry, you can't read the ruler on the side of it. There is no identifying factors to say whose wound it actually is. So making sure, and it might be within your own organisations, it might be reviewing the equipment that you have, making sure that there's consistent approach, getting some education on how exactly you need those photos to look for your wounds. Now, most electronic care systems, there's the function in there, but again, making sure that there's a consistent approach from everybody who's managing the wounds in your service, so that each and every time we can actually monitor properly how the wound is progressing. It's very difficult to identify if there's deterioration or improvement if you've got inconsistent photos. The clinical oversight piece is also very important. So thinking about in your own services and organisations, how you actually escalate clinical concerns. Who's checking? Who's checking to say, we've got this many pressure injuries. Of those, we've got 5 that are a stage 2. And actually, we only had 2 stage 2s last week. What's going on here? What is it that we need to be doing? How are we making sure from a governing point of view, we're governing well? Monitoring and surveillance. So again, through your own systems, what's the process for monitoring and really checking on the wounds? Have you got that clearly articulated in your policy and process documents? Utilising wound specialists. So obviously for HARTMANN's customers, people like Kate and her team, but also where you need to outsource to wound specialists, making sure that you do have systems in place where your teams can escalate. On that, once you have utilised a wound specialist and they've given you all of these recommendations, making sure that they're implemented. Because again, one of the areas that we see people come really unstuck is that they have actually done a great referral. Some feedback has come back of try X, Y, and Z, but it hasn't been covered. It hasn't been carried through all the way in which it needs to. So making sure that you've got a checking mechanism, again, coming back to your clinical oversight, how do we make sure that when we've referred externally, actually those recommendations are carried through? How are they evaluated to make sure that it's effective as we need it to be? And finally, thinking about the use of equipments and aids. So air mattresses, heel lifts, tubing grifts, offloading equipment. One that I definitely call out there, Kate, is the use of air mattresses and pressure relieving devices. The importance of having checking mechanisms in place to make sure that they're on correct settings. Now, many of them now auto set, but we know that there are still products in existence where they're dependent on people's weight, making sure that we've got the right setting in place for somebody. So that we're not actually having the pressure relieving devices cause harm where they're intending to minimise harm. So, Kate, let's have a bit of a look at a case study in the last couple of minutes that we've got. And I love a case study because it really tries to bring everything together. So we've got Mrs. Agnes, who is an 85-year-old who has recently moved into residential aged care. She has a history of diabetes, hypertension and peripheral vascular disease, osteoarthritis and incontinence. Prior to her admission, she was living at home with home care support provided 3 days a week. She's developed redness to her sacrum in the pelvic region as she has been spending more time in bed. This has not been noted until recently. She was transferred to hospital with increased confusion and fever. It was identified that she had developed a wound and a pressure injury on her sacrum that had not been dressed or cared for and is now infected. So, Kate, this is obviously quite a complex and concerning issue for Mrs. Agnes. What are some of the things as a registered nurse we'd be thinking about from a key assessments point of view?
Yeah, I think those diagnoses are pretty common when we think about the number of complex disease processes that your typical consumer will have. So, diabetes, peripheral vascular disease, already thinking high risk for wounds to, lower limbs, osteoarthritis, restriction of movement. But then when we think about the wound that she has currently, incontinence, we know that there's contributing of moisture there. When we talked about urine, feces exposure, higher pH than when the skin likes to, where the skin is. So, potentially there was an IAD there. We know she spent more time in bed. So then thinking, okay, pressure injury. Obviously, you need to be able to assess the wound to make that assessment by going, all right, how am I going to differentiate? That's the key thing for a registered nurse. They're going, how am I going to differentiate your IAD to your PI? And how am I going to support that clinical decision with clinical reasoning and documentation to support it, support the why? And then thinking about, okay, well, if it's infected, going to your time process, thinking about what's the tissue management process here? What's that inflammation process? What is the moisture? How do we promote that moisture balance? And then as well thinking about that epithelial age advancement. So they're probably the key things that I'm going red flags: continence or incontinence here, and that reduction of mobility. For now, it sounds like there's an infection there that we do need to get on top of. And that's when it's really good to refer to that wound infection continuum. If we're thinking a pressure injury, I guess, in that pelvic region, and we know that there's incontinence, maybe reviewing those, what continence aids are we using, making sure they're continence aids that are helping to buffer that pH of urine, and also making sure that they're that rapid fluid distribution as well. So it's not just sitting in that continence aid. So that whole continence promotion piece as well. Obviously, with that pressure, we want to be looking at, as that last slide covered off, the equipment, but also what is Mrs. Agnes's, what is her understanding here? What is her health literacy? How can we get her up and moving again? How can we have that health promotion and healthy aging promotion here with her? Thinking about what her goals are. So yeah, I think that's a starting point, some of the key things.
Yeah. Kate, one of the things that kind of stands out to me, and this is probably my compliance hat talking, is, well, if Mrs. Agnes has actually developed a pressure injury that hadn't been dressed or cared for and now it's infected, what are the compliance issues that we need to be thinking about? Have we looked at this to determine whether it's a SIRS, whether it's a P1 or it's a P2? Are we doing critical incident investigation, or what is your policy saying around, well, this has been identified? To me, this would be a SIRS because it's gone from it's gone undetected. How are you then going about addressing that with your teams to prevent that from happening again? Now, if Mrs. Agnes is still in hospital, we'd be thinking, when she returns, what are some of the baseline assessments that we'd be doing? And you've talked about the majority of those there, but yeah, thinking really broadly around, well, if this has happened to Mrs. Agnes, who else could this be happening to in my service? So connects to education. How do we make sure, again, that people are really clear of what they should be looking for and what their requirements are in terms of their role and pressure injury management?
Yeah, and it links back to that the holistic skin promotion piece as well. Every consumer who has incontinence, how are we promoting their skin integrity? Do we have a barrier cream? If we're using a barrier cream, we need to make sure that it's not one that blocks the polymers, and therefore when the continence aid becomes null and void. So that first slide where we talked about the different of the Molicare skin products, they're all in that pH skin region, and they're going to protect that skin. So we know that therefore is going to reduce the likelihood of an IAD occurring. And then we're thinking about those pressures as well. So that skin integrity piece is so paramount.
Yeah. Okay, just in the interest of time, what other support services are available? I think we've touched on some of the external wound referrals. What other things would you be thinking about there in that piece?
I think it's really important to link in with, allied health as well. That healthy aging and health promotion piece is so important. It shouldn't just be after the fact. It should be part of that holistic, okay, we've got a wound to the sacrum. We want to get this, we want to get Mrs. Agnes's mobility back. So really tapping into your allied health, great resource. Thinking about the nutrition as well. She's had some deterioration. If she's been in bed more, has she been eating? How are we going to get that wound healing? How are we going to get her feeling like up and wanting to do things? So.
Thanks, Kate. I'm just going to let you touch on some of the really great resources that you've got through the HARTMANN's range.
Yeah, so this is just a shout out to some of our key resources we have when we're talking about that last slide, training for carers and stuff for your team. around, you know, carers using your preventative skincare and incontinence aids. We've got resources that support that from a preventative and everyday reassessment approach. We've also got resources and pathways that support with your wound management, whether that be pressure injury, leg ulcers, skin tears. We've got time posters. There's also others to support your IAD versus PI differentiation. So if you would like any of these resources, feel free to reach out, and we can talk through some solutions to support with your clinical governance and your wound management. And then on the next slide here, this is our Simply app. So feel free to scan the QR code or download it from your app store. Essentially, it can help you with your wound selection process. So it can go through whether you've got a skin tear and some relevant parameters of that wound, and then links to the products. You can also search by product. So if you want some more information on any of the products. The other call out here that I wanted to make note of is our Link Hub. Now, this is an online learning platform that has a heap of resources around wound care. They are all CPD points. It's run by a global platform. There's webinars on there. There's self-directed e-learning modules. So that's all free and readily available through our Simply app. So feel free to download that as well.
And Kate, I can definitely attest to the Simply Wound Care app. I downloaded it since we've been doing this work, and it's a really great tool to have at your fingertips. So again, for the clinicians, most of you would be using electronic care systems. So seeing how you can get this, if you've got tablets and devices, get your IT team to think about how they can automatically load it onto your phones for you. For Anchor Academy and Anchor Excellence, I just really like to give a quick plug for our sessions that we have as well. So we have a whole range of sessions on Anchor Academy platform. We have clinical essentials, clinical management and governance essentials. And then we've got a whole lot of sessions that are really designed at addressing some of the key risk issues that we see in our work with our clients. So if you would like a little bit more information on that, please have a look at our website or get in touch. I'd be very happy to help you out. We can see Kate's obviously been a very good university student and done an amazing reference list there. So Kate, thank you for putting these resources in, but references. Encouraging everybody again, if there's particular things that you want to do a little bit more follow-up work on, have a look at these references because they've all contributed to the slides that we have here today. So I'm going to stop sharing now. So thank you, everybody, for joining us today. Thank you for all of the work that you do out in the industry. We know that it is very difficult. We acknowledge that it's probably one of the most difficult places to be working at the moment, and we genuinely say thank you for your hard work and your contribution, and we wish you all the very best, and we hope that you've enjoyed today's session. Thank you so much.
Thanks so much for joining.